I don't think there's anything related to the current presentation. And right now I would like to focus on lung and diaphragm protective ventilation during assisted ventilation, because I think that's even more interesting, right? Because now there are two forces acting on the lung, the ventilator and forces generated by the respiratory muscles. And now the impact on the respiratory muscles in itself is interesting and important as well. So what I would like to do in this 15 minutes is discuss the impact of respiratory drive and effort on the lung and diaphragm. Can we quantify respiratory drive and effort? And how do we set the ventilator to protect both the lung and the diaphragm? So quickly review the physiology of respiratory drive. What is respiratory drive? It's the output, the electrical output of the respiratory centers in the brainstem. And the electrical output, the respiratory drive, depends on input from pathways in the body. Most importantly, chemoreception. The strongest predictor of respiratory drive is arterial pH, and to a lesser extent, arterial PO2. Secondly, input from higher brain centers. Agitated patients, anxious patients, or neurotrauma patients often have a high respiratory drive. And finally, there's feedback to the respiratory centers from pulmonary reflexes. So, irritant receptors in the lung, patients with pneumonia, inflammation, usually have a high respiratory drive due to activation of these irritant and stretch receptors. So the consequence of respiratory drive is respiratory effort. So these are different entities. Usually, a high respiratory drive results in high effort, but not in the case of respiratory muscle weakness. So respiratory effort is generated by the respiratory pump. So what are the clinical consequences of drive and effort? Well, in patients with a very low effort, as Jean-Daniel already showed, they are at risk for respiratory muscle atrophy, at risk for poor patient-ventilator interaction and sleep fragmentation. While on the other hand, a high respiratory effort, as shown, may result in lung injury, diaphragm myotrauma, hemodynamic consequences, and especially a high drive, not a high effort, but high drive, is associated with dyspnea sensation. So this is important. I'm not going to show this slide, Jean-Daniel has shown it before, but I want to focus a little bit more on respiratory muscle weakness. This is a very nice study by the group from Martin Dress and Alexander de Moule, looking at patients that had been on invasive ventilation for at least 24 hours. At the time of the first spontaneous breathing trial, 63% of the patients had developed respiratory muscle weakness. So we do have a problem here, right? You've seen this slide. One of the explanations, if we look at the structural changes in the diaphragm, is atrophy, probably resulting from disuse. But if you look more closely, and these are data from biopsies that we took of the diaphragm from real ICU patients, we'll see it's not only atrophy. There's inflammation as well. The diaphragm is infiltrated by all kinds of inflammatory cells, and more recently we found there's actually fibrosis of the diaphragm, and that cannot be explained by just disuse. So what is the pathophysiology? What explains diaphragm weakness? Well, there is a role for denutrition. There is a role for sepsis, but that's not what I want to discuss right now. I would like to discuss the role of mechanical ventilation. And on the one hand, as we already mentioned, excessive unloading results in inactivity of the diaphragm and disuse atrophy. But on the other hand, we're starting to realize, but we don't have very strong evidence, but we're starting to realize that a high effort, so insufficient unloading of the diaphragm, may result in trauma, myotrauma of the diaphragm as well, resulting in dysfunction. So if this is the case, then in patients on assisted ventilation, we should be aiming for a physiological breathing effort. On the one hand, to protect the diaphragm, we don't want total inactivity of the respiratory pump, but on the other hand, to protect both the diaphragm and the lung, we don't want to have too high breathing effort, right? So how can we quantify respiratory drive and effort? I still think that the state-of-the-art technique is esophageal pressure, but I'm not supposed to talk about that because Lisa Picchio will do that in a couple of minutes. So are there non-invasive ways that we can estimate breathing effort? And I think maybe. So let's look at P.1 and P-OC, the occlusion pressure. And we actually just published a paper where we specifically looked at whether these non-invasive markers indeed can be used to estimate breathing effort as compared to this gold standard. But first, to remind, what is P.1? And there has been fantastic publications by Irene Talias from the group from Toronto that actually described everything related to P.1. But the P.1 is the decrease in airway pressure during the first 100 milliseconds of an occluded inspiration. And actually that can be measured by every ventilator, and some ventilators don't even need the occlusion. They even allow it to calculate it from just the triggering phase. So the P.1 is the drop in airway pressure during the first 100 milliseconds of inspiration. Does it provide a good estimation of diaphragm effort, transdiaphragmatic pressure? Well, going short, P.1 is very good in detecting patients with a low breathing effort, but not so good, as you can see in the ROC curve right here, it's not so good in detecting patients with a high breathing effort. So what about P-OC, the occlusion pressure? I think that has been first described by Bertoni, also from the group of Toronto. The occlusion pressure, as can be seen right here, so this is a patient on pressure support, and if you perform an end expiratory occlusion, there will be a drop in airway pressure. And as I just explained, the P.1 is the drop in pressure during the first 100 milliseconds, and the P-OC is the total drop in airway pressure. So how does P-OC perform in predicting the effort generated by the diaphragm? Well, as you can see here in the ROC curve, it's very good in identifying patients with low breathing effort, and also in identifying patients with high breathing effort better, at least better than the P.1. So, and this is point of discussion, but I think it is reasonable. A physiological activity of the diaphragm is a pressure between 3 and 12 centimeters of water. If you believe that, which is reasonable, you could aim for an occlusion pressure between 7 and 15 centimeters of water. That could be diaphragm protective. The other interesting question is, can we use P-OC to deliver lung protective ventilation? As you will know, so this is a patient on pressure support ventilation, 10 of pressure support. As you know, the increase in airway pressure during pressure support does not reflect the driving pressure, right? As would be the case if the patient is on controlled mechanical ventilation, because in a patient on pressure support ventilation, the lung distending pressure is determined by the change in airway pressure delivered by the ventilator, plus the pressure developed by the respiratory muscles. So, and I think that's actually quite nice. In 2 independent cohorts, the group from Toronto and our own group found that the dynamic transpulmonary driving pressure can be quite reliably calculated by P-OC times 0.66 plus the pressure developed by the ventilator. So, for instance, if your inspiratory support is 10 centimeters of water, the P-OC is 12 times 0.66, the dynamic transpulmonary driving pressure would be 18 centimeters of water. So to conclude this one, I think that still esophageal pressure is the gold standard to assess breathing effort, but the POC is a nice non-invasive way to assess respiratory effort and dynamic transpulmonary driving pressure. Okay, how are we going to set the ventilator? Well, I started out with these are the three factors that determine respiratory drive that we should modulate. That we could modulate, I should say. Well, I'm not supposed to talk about sedation or extracorporeal CO2 removal, but I can talk about changing inspiratory support, right? So that's what we did in this trial. So this was a feasibility trial on an assisted mode, equipped the patients with a double balloon catheter, so we could measure transdiaphragmatic pressure, and the patients were randomized between standard of care or titrating diaphragm effort between 3 and 12 centimeters of water, what we called a diaphragm protective range. This is quite complex. The fact is, if diaphragm effort was low, we reduced the level of inspiratory support. If diaphragm effort was high, we increased the level of inspiratory support. Right here, you'll see on the x-axis the first 24 hours, and right here on the y-axis the percentage of breaths in the in the diaphragm protective range. In the control group, it was 35% of the breaths, and in the intervention group, 81% of the breaths. So yes, it is possible to be more likely in a diaphragm protective range by titrating support. Does this challenge lung protective ventilation? No, because tidal volume and transpulmonary driving pressure was the same in both groups. So now I was asked to make a kind of algorithm on how to set the ventilator to protect the lung and the diaphragm. It's quite complex, but I'll try to get you through. Key is here to measure POC. And really, it's simple. You can do it on every ventilator. So you start to measure POC and calculate the transpulmonary driving pressure. So that's your inspiratory support plus 0.66 times POC. We first want to be sure it's lung protective. If this transpulmonary driving pressure is below 22, we're looking at diaphragm effort. If diaphragm effort is low, you could consider to reduce the level of sedation or lower inspiratory support. If effort is high, there's probably under assistant, then you could consider increasing the level of support. On the other hand, if you calculate transpulmonary driving pressure, and it's high, more than 22, and the occlusion pressure is low, probably the patient is in over-assist, so you could reduce your level of inspiratory assist. This is simple. It does work in the trial, but it requires, of course, clinical validation. But it's something you can start out with if you want to do lung and diaphragm protective ventilation in an assisted mode. Given the time, I'm going to skip this, but it's very important. Interesting to know that you also can modulate drive and effort by changing your level of PEEP, but I don't have the time for that right now. So my key messages are here. I think POC provides a good or reasonable estimation of respiratory effort, but take the average of 2 or 3 maneuvers. The POC provides an estimation of the dynamic transpulmonary driving pressure by the formula as found by our group and by the group from Toronto. And this proposed algorithm, I think it's reasonable, but it requires further clinical validation. Thank you so much for your attention.
Are there questions from the audience? Yes, please. Can you introduce yourself?
Yeah, hi, Giovanni from Calgary, Canada. Just a quick question, probably it's a silly question, but the P occlusion, the P occlusion is an isometric contraction. How can we infer from an isometric contraction the tidal breathing then is a concentric contraction? How can it, because what we want is a protective concentric contraction. From an isometer. Yeah, thank you.
You're completely right. As you can see right here, so this is the esophageal pressure. Can you see the pointer? Yes. So this is the esophageal pressure during assisted breathing, while the patient is in pressure support, right? Now we have this end inspiratory occlusion, and you can see that the change in esophageal pressure is a little bit larger as compared to the previous breath. And that is why we multiply the POC times 0.66 to get this pressure. And the pressure delivered during occlusion is a little bit higher because, as you say, it is isometric. And, well, I think that's the most important thing. It's isometric, and maybe because the patient puts a little bit more effort in it. So what we did is take this value and looked at the changes in esophageal pressure in the hour before. So that's why you cannot say if POC is 12 centimeters of water, the pressure developed by the diaphragm is 12 centimeters of water during assisted breathing. You have to multiply this 12 by 0.66. So that's an excellent observation, yes.
Okay. Yeah.
Yeah,
there is a question from the floor. What do you think of closed-loop ventilation? Is it feasible to protect lung and diaphragm?
Well, I think also with closed-loop ventilation, if closed-loop ventilation is NAVA, I think you still have the same thing. If the drive is very high, it's very hard to control the patient, whatever the mode. If closed-loop ventilation means that it automatically decreases the level of inspiratory support, it might partly fit with this algorithm, right? So, but again, if the patient has a very high respiratory drive, in some of these patients, you will be unable to manage it with the ventilator. You have to do something else, increase sedation or whatsoever.
Leo, you showed an algorithm, yeah, exactly this one, where your lung stress limit is 22, which is the transpiratory pressure. So maybe for some people that may look very high because we are used to a driving pressure delta P on the ventilator of 15. Now you're looking at the lung and you're accepting up to 22. Could you comment a bit on that?
Yeah, so that's a very important question. And honestly, myself, I also thought initially, wow, 22, that's much, much higher than the 15 centimeters of water we would allow during controlled mechanical ventilation. But it is very important to realize right here that this is a dynamic transpulmonary pressure. And actually, but this is very preliminary data, from 4 different cohorts around the world, we have found that this 22 centimeters of water equals a static driving pressure of 15 centimeters of water, as determined by an end inspiratory hold. So yes, so this 20, it's 22 here, maybe 20 would be a little bit more on the safe side, but this 22 equals the, well, driving pressure, the static driving pressure of 15 centimeters of water. But as you can hear, I'm careful here, right? So this is a proposed algorithm as we use it in our ICU, but...
There are two questions on PMI. Do you use it in your clinical practice, and do you think that we can use it to set the ventilator?
Now, honestly speaking, no. We are not using PMI in our clinical protocols. I think if you can use like one marker, if you can implement one marker in your clinical practice, you're already taking the good steps, right? And I think today POC has been best validated. It's easy to perform. The PMI, I should say, is an end inspiratory occlusion while a patient is on pressure support ventilation. There's great data from your group, from Giacomo Bellani, that shows that this PMI can be used to estimate driving pressure in patients on an assisted mode. The problem is that it's not feasible in all patients, so you have to be careful, have to look at certain quality criteria. I think it's a little bit more complex and a little bit less validated as compared to POC. So that's the reason, honestly speaking, that we would prefer POC.
Thank you. Thanks, Leo.